Assalamu alaikum. It is the fifth part of this uh, group of lectures regarding obstetrics and gynecology. Starts with this ovarian torsion. What happens in ovarian torsion? Ovarian torsion actually happens when there is an ovarian mass, woman of the reproductive age, infertility treatment with ovulation inducing drug. If there is ovulation inducing drug is used or in a reproductive age, and if there is ovarian mass, there is sudden onset pelvic pain, nausea, vomiting, and palpable adnexal mass. Ultrasound adnexal mass with absent Doppler to ovary. Adnexal mass with absent Doppler to the ovary. Treatment is laparoscopy with detorsion, ovarian cystectomy. This is ovarian torsion. This is the occluded vessel. This is the uteropelvic ligament. This is the infundopelvic ligament. Normal ovary. This is edematous ovary. There is torsion happens. There is torsion happens. Laparoscopy with detorsion, ovarian cystectomy, and oophorectomy if necrosis or malignancy. Torsion initially impedes the venous flow with continued arterial inflow leading to vascular congestion and edema. Persistent torsion can cause acute onset severe pelvic pain due to ovarian ischemia and necrosis from complete ovarian vessel obstruction. It can lead to peritonitis, fever, nausea, vomiting, and acute abdomen. Ovarian torsion is precipitated by physical activity, and the initial pain can be colicky and causes of partial torsion, intermittent adnexal twisting, and untwisting. However, when progression to complete torsion, patient typically develops severe unilateral lower abdominal pain with nausea and vomiting. The ovary can become enlarged, edematous, tender, and have associated inflammatory pelvic free fluid. Although ovarian torsion is usually diagnosed clinically and confirmed surgically, a Doppler ultrasound can support the diagnosis and decision for surgery. Ultrasound classically shows adnexal mass with absent. Ultrasound classically shows adnexal mass with an absent Doppler blood flow due to occluded ovarian vessel. It can be normal with partial torsion due to adnexal untwisting. Here, normal findings do not exclude the torsion because of the risk of tissue necrosis and loss of ovarian function, infertility, and menopause. Ovarian torsion requires diagnostic laparoscopy to manually untwist the adnexa and restore the blood flow. If the partial ovarian torsion typically presents with intermittent self-resolving episodes of unilateral pelvic pain due to temporary ovarian vessel occlusion. Patients with intermittent partially torsion can suddenly develop complete torsion, which require diagnostic laparoscopy. Any large ovarian mass more than 5 cm can induce torsion. However, mature cystic teratoma, also known as dermoid cyst, common in premenopausal women. Women have an elevated risk due to their heterogeneous composition and variable density that creates an unstable mass prone to rotation. Now, theca lutein cyst. It is multilocular, bilateral, 10 to 15 centimeter of the ovaries. Pathogenesis is ovarian hyperstimulation due to GTH, gestational trophoblastic disease, multiple gestation, and infertility. Theca lutein cyst resolves with decreasing beta HCG level. It is multilocular, bilateral, happens due to ovarian stimulation, results with decreasing beta HCG. Simple cyst occurs if the follicle fails to rupture during ovulation. Simple cyst with unilateral or unilocular on ultrasound. Tumors. A palpable adnexal mass on physical examination is best evaluated by a palpable adnexal mass on physical examination is best evaluated by pelvic ultrasonography to rule out the malignant feature. CA125 has particularly low specificity in premenopausal women as it can be elevated from any other benign condition like endometriosis, leiomyomata, lupus. Ovarian cancer is less common before menopause. CA125 is useful mainly in the post-menopausal. So before menopause, CA125 is a unnecessary test. A CT scan of the abdomen and the pelvis is may be necessary in the adnexal mass may have malignant features on ultrasound. A CT scan is reserved for detection of the metastasis from ovarian cancer. MRI scan of the abdomen and pelvis provides excellent delineation of the soft tissue. It is significantly more expensive and less readily available and therefore not a first-line choice for pelvic imaging. So, a post-menopausal adnexal mass evaluation, adnexal mass present malignant features on ultrasound, like there is increased vascular septation, calcification present. If the present, additional imaging and surgical management may be needed. Additional imaging, that means CT scan of the abdomen and the pelvis um, for looking for metastasis, and then surgical treatment. If malignant features not present, then CA125 done. If it is normal, then observation and serial ultrasound should be done. Ovarian masses in postmenopausal women are initially evaluated with a pelvic ultrasound. In postmenopausal women with a benign appearing mass CA125 level, further risk stratify the mass either likely benign or malignant to further guide for management. In premenopausal women, most adnexal mass are due to benign causes. Functional cysts are the risk for malignancy is low and therefore asymptomatic patients are managed with reassurance and observation. Tumor screening. Risk for ovarian cancer screening and management. Family history. Low or average risk, no screening needed. For high risk patients, the following multiple members on a side of the family with breast cancer or ovarian cancer, male breast cancer, bilateral breast cancer, diagnosed age less than 50, Ashkenazi Jew ancestry, 3 or more than 3 relatives with the Lynch syndrome associated cancer, hereditary cancer syndrome testing BRCA1, 2 and Lynch syndrome. If it is positive, then concurrent TBUS, transvaginal ultrasound and CA125 every 6 months, beginning at age 30. And risk reduction bilateral salpingophorectomy upon completion of the childbearing. If negative, if hereditary BRCA1 to Lynch, no screening OCP for premenopausal women. Risk reduction bilateral salpingophorectomy postmenopausal women partially at the time of hysterectomy for benign result. So for low and average risk women, such in this patient ovarian cancer screening is not indicated or is not indicated because it's not effective in for early diagnosis. Reduction in the mortality only increases the false positivity results. Due to high risk ovarian cancer in women who test positive for BRCA1 and 2 and pelvic ultrasound and CA125 are recommended every 6 months, beginning at the age 30 until undergoes risk reducing bilateral salpingo-oophorectomy. Okay, then mature cystic teratoma or dermoid cyst. Okay, mature cystic teratoma or dermoid cyst. Mature cystic teratoma or dermoid cyst. It's a benign ovarian germ cell tumor. It's a benign ovarian germ cell tumor. The mostly asymptomatic clinical feature is ovarian torsion may happen. It may come with struma ovary subtype, hyperthyroidism, unilateral adnexal mass, and ultrasound complex cystic calcification. In massive cystic teratoma or dermoid cyst, there is complex cystic calcification. As teratoma in here, all sorts of things we can get. Gross appearance, sebaceous fluid, hair, teeth. Ovarian cystectomy or oophorectomy may be done. There is intermediate. Teratoma typically appears as an adnexal mass with a composition of ultrasound as calcified mass, multiple thin echogenic bands, multiple thin echogenic bands like hairs, but definite diagnosis after ovarian cystectomy. Definitive diagnosed after ovarian cystectomy. Dermoid cysts have solid components but do not exhibit multiple septate or cause ascites. It has this sort of unique feature. Serous ovarian cancer. Serous ovarian cyst adenocarcinoma. These serous ovarian cancer, pus filled with multiple cysts filled with serous fluid. This is the atypical epithelial cell on stromal invasion. Complex mass with solid component. However, they are typically not calcified or hypertrophic. The ovarian abscess has sonographic appearance, multiloculated cystic adnexal mass. Unlike this patient, they are typically no echogenic nodules or calcification. Ovarian endometrioma, homogeneous cystic mass with a diffuse ground glass appearance. Ground glass appearance is ovarian endometrioma. LDH secreting tumor is dysgerminoma. LDH secreting tumor is dysgerminoma, where there is increased beta hCG, increased LDH. On histology, there is fried egg appearance. Histology, there is fried egg appearance. Embryonal carcinoma is a type of germ cell tumor that occurs typically in young women. And Yolk-sac tumor are also germ cell tumor. Before jumping into this, I would like to discuss about this. This is malignant ovarian neoplasm. In malignant ovarian neoplasm, epithelial is serous cyst adenocarcinoma, mucinous cyst adenocarcinoma, and dysgerminoma. These three are epithelial origin. From here, serous cyst adenocarcinoma I have already make you seen. Most common ovarian cancer of bilateral histology, samoma bodies. A mucinous cyst adenocarcinoma is pseudomyxoma peritonei, and mucin producing epithelial cell is present, and dysgerminoma is increased LDH, beta acids, I, and fried egg appearance. Germ cell tumor is high alpha fetoprotein and aggressive and Schiller dual body resembling glomeruli and stroma, granulosa cell tumor, and certainly Leydig cell tumor. Increased estrogen, increase in heparin. Histology is colleagues in our body, coffee bean nuclei, and certainly Leydig cell tumor, androgen, hirsutism, and clitonomegaly. This is epithelial ovarian carcinoma. In epithelial ovarian carcinoma, there is serous, there is mucinous, and there is G germinoma. Before jumping into the histological pattern, it is abdominal pain, bloating, and early satiety may come with abdominal pain, bloating, and early satiety in acute dyspnea, obstipation, or constipation, and abdominal distension may come with abdominal distension. Risk factor is family history, genetic mutation, BRCA1 and 2, age is 50, age more than 50, hormone replacement therapy, endometriosis, infertility, early menarche, late menopause. Protective factor, oral contraceptive, multiparity, and breastfeeding. And lab finding is CA125, solid complex mass, thin septation, and ascites. Solid complex mass, thick septation, and ascites. Surgical exploration, laparatomy, with or with chemotherapy. Epithelial ovarian carcinoma refers to the malignancy involving the ovary, fallopian tube, and the peritoneum. Histologically, abnormalities can be benign at any of these sites, presence with a hallmark of large ovarian mass and a widespread pelvic and abdominal metastasis regardless of primary origin. A firm, non-mobile pelvic mass with nodularity in a postmenopausal patient is concerning for epithelial ovarian carcinoma. Imaging, pelvic ultrasound, exploratory laparatomy should be done, and surgical staging is required. Chemotherapy is platinum-based agent is initiated after surgery. An ovarian mass in a postmenopausal patient is highly concerning for malignancy. Pelvic ultrasound CA125 measurement is necessary. This is the high yield. In epithelial ovarian biopsy could lead to rupture of the mass and resulting in spreading of the cancerous cell. So needle aspiration is contraindicated in postmenopausal women with adnexal mass due to risk of spreading potentially malignant cell. Should the mass prove cancerous. Brainer's tumor are rare, benign subtype epithelial ovarian cancer is typically found incidentally in asymptomatic patients. Then granulosa cell tumor, In granulosa cell tumor, histologically called exner bodies found. In juvenile subtype, there may be precocious puberty, adult breast tenderness, and abnormal uterine bleeding may be found. In granulosa cell called exner body, histopathologically, and endometrial biopsy should be done. So if a patient comes with a precocious puberty or on breast tenderness or abnormal uterine bleeding, look increase estrogen, increase in heparin, look for this type of tumor. What is the next best step of endometrial? Next best step is endometrial biopsy. Premenopausal women desiring future fertility who have granulosa cell tumor, no endometrial cancer can undergo uterus sparing. 。  procedure. Endometrial cancer can undergo uterus sparing procedure. Unilateral salpingectomy can be done. In contrast, patients with bone, granulosa cell tumor, and endometrial cancer require hysterectomy and bilateral salpingo. So, premenopausal women only who have granulosa cell tumor, no endometrial cancer, can undergo uterus sparing procedure, unilateral salpingo-oophorectomy, but they do not need hysterectomy. They can spare the uterus. Premenopausal women with only granulosa cell tumor. This is very high. Patient managed surgically and required monitoring the disease progression by recurrence can be seen by seeing the inhibin level. By seeing the inhibin level. Now, Sertoli-Leydig cell tumor. In Sertoli-Leydig cell tumor, there is this is sex stromal tumor. There is increased testosterone. There is increased testosterone. Rapid onset, virilization, voice deepening, increased muscle mass, clitoromegaly, oligomenorrhea. There is voice deepening, oligomenorrhea, clitoromegaly may happen. Surgery. Voice deepening is common sign of frank virilization is a common sign. Voice deepening is a common, possibly irreversible sign of frank virilization as excess androgen, testosterone more than 150, and dihydroepiandrosterone sulfate more than 700. Lengthen and thicken the vocal cord. These lengthen and thicken the thereby changing their acoustic frequency, changes their acoustic frequency and changing the voice. Voice deepening is possibly irreversible. Voice deepening uh, is a good sign for diagnosing these six Sertoli-Leydig cell tumor. Rapid onset virilization, clitoromegaly, testosterone dehydrotestosterone affect the peripheral tissue resulting in clitoromegaly. Signs of estrogen deficiency, testosterone inhibits hypothalamic gonadotropin releasing hormone and pituitary FSH-LH release resulting in low estrogen. Therefore, patients may develop breast atrophy, vulvovaginal atrophy, dyspareunia, and oligomenorrhea. Patients with rapid onset less than 1 year of virilization should be evaluated for androgen secreting tumor, of ovarian and adrenal origin. An elevated testosterone level and normal dihydroepiandrosterone sulfate level are typically due to an ovarian source of Sertoli-Leydig cell tumor. In contrast, elevated dihydroepiandrosterone and normal testosterone levels are typically due to an adrenal tumor. Ovarian thicoma is a benign sex-cord stromal tumor typically occur in postmenopausal women. Thicoma may secrete estrogen and abnormal uterine postmenopausal bleeding. They do not cause virilization. Anti-NMDA receptor encephalitis is a psychiatric syndrome characterized by cognitive function, psychosis, seizure, instability, hypothermia, hypertension, dystonia. It occurs most commonly in young women. Median age 21 is associated with ovarian teratoma. So, autoimmune encephalitis syndrome characterized by psychiatric symptom, anxiety, psychosis, cognitive dysfunction, seizures, autonomic instability, hyperthermia, hypertension, tachycardia, dystonia, rigidity. This type of patient has underlying ovarian teratoma in 50% cases. So association should be found. Association should be ruled out. Regardless presence of tumor, immunosuppressive treatment is a cornerstone of the therapy. Recovery is slow, 4 to 5 days. Now endometrium Asherman syndrome, very important topic. It Asherman syndrome due to infection and intrauterine surgery like curettage and myomectomy and infection, septic abortion and endometritis, abnormal uterine bleeding, amenorrhea, cyclic pelvic pain, recurrent pregnancy loss. Hysteroscopy should be done in Asherman. Infertility, inability to conceive after 6 months of unprotected intercourse in women more than 35. Inability to conceive after 6 months of unprotected intercourse in women more than 35, and after 12 weeks in women aged less than 35. Patients who undergo intrauterine surgery are at risk of damage of the endometrial basilis layer. Lack of endometrium results in development of secondary amenorrhea, fertility, and a negative progesterone level test. Cause of abnormal menstrual bleeding, fibroid, adenomyosis, and endometrial cancer. Fibroid, adenomyosis. In abnormal uterine bleeding, there is sperm count, polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory, uh, maybe infection, and not yet classified. This is sperm count classification for abnormal uterine bleeding. It's a menstrual bleeding that is prolonged more than 5 days heavy and prolonged more than 5 days and heavy more than 1 pad every 2 hours with irregular frequency. Private heavy means constipation, urinary urgency, pelvic pain, and enlarged uterus. Adenomyosis, dysmenorrhea, pelvic and heavy means bulky globular tender uterus, bulky globular tender uterus, and endometrial cancer, non-tender uterus. Tender uterus is adenomyosis, non-tender uterus is endometrial carcinoma, and enlarged uterus is fibroid. Adenomyosis age more than 40, multiplicity, prior uterine surgery, myomectomy, comes with chronic pelvic pain, diffuse uterine enlargement. Clinical presentation, MRI ultrasound, thickened myometrium, confirmation by histopathology, and hysterectomy should be done. Hysterectomy should be done in adenomyosis. In adenomyosis, hysterectomy should be done. So in adenomyosis, age more than 40 characterized by new onset, multiparous woman comes with new onset dysmenorrhea, and heavy menstrual bleeding and progression to chronic pelvic pain, boggy, tender uterus on examination. Symmetrically, which is a concentric symmetrically enlarged uterus but does not exceed 2. It does not exceed 12 uteruses. It is important. It's a tender uterus, boggy, tender uterus on examination, age more than 40, multiparous women with new onset. In contrast, fibroid typically, fibroid is firm, not floppy, and non-tender. Fibroid firm and non-tender. This is the IL. Fibroid firm and non-tender. And fibroid can exceed more than 12 weeks. Initial work of adenomyosis for pelvic ultrasonogram or MRI, and a definitive diagnosis is made histologically after hysterectomy, which is treatment for patients who do not improve with conservative management. And that is the fifth part of my lecture. Okay.